Today we are here to talk about the ever-encompassing value-based purchasing that is upon us. As many of you know, and as many of you have participated in, we had a 5-year demonstration with value-based purchasing that just ended at the end of 2020. The value-based purchasing model was inclusive of the 9 states that you see on the screen. Those 9 states that you see in gold are the only ones that have participated in the actual demonstration. As you can see on the screen, we had 47% of the total volume of home health agencies that were included in the demonstration were in the state of Florida. The volume of agencies we feel like probably impacted somewhat the results, but having said that, we're getting ready to move into 2023 where we're going to have a situation where agencies that are required to participate in HHCAPS, meaning volume wise, you're going to be in the bucket with 7,500 other agencies. But with the demonstration that did occur over the 5 years ending in 2020, every agency in the individual states were only compared in the calculations to other agencies within the same state. So it is going to be a rude awakening for many of them. And some of the statistics that I'm going to share with you a little bit later, I think you will definitely understand. So as we go through this presentation today, I want you to type any questions that you have in the Q&A box that you should have at the bottom of your Zoom screen. And I will try to answer those questions as we go. It is imperative that you are fully aware of all of the individual items that are going to go into the calculation for value-based purchasing and what those calculations can result in as far as payments. And we're going to take you through those today. In addition to that, I have given you some very detailed screens as far as the content of the OASIS items that go into the calculation and the HHCAPS specific questions that go into the calculation as well. We are not going to be able to elaborate on each of those questions today because of our time frame, but I did want to put them in the presentation so that if nothing else, you can use them as examples when educating your staff. So we're going to look at, the first thing we're going to look at is the 5th year annual report that was issued at the end of 2020. Well, it was issued in 2021, but of course, encompassing all 5 years of the demonstration. Because of the fact that the 5th year of the demonstration happened in 2020, with the public health emergency ensuing, they did not impose any financial impact on individual agencies, whether that be positive or negative. No one was impacted financially by the results of 2020. But this annual report that they issued that you can find on the CMS website does go through all results compiled for all 9 states and does report that regardless of the public health emergency. So as you can see on this page, in that 5th annual report, they are telling us that we, in the value-based purchasing states, saved the Medicare fund $949 million in those 9 states alone during the value-based purchasing 5 years. Their breakdown of that is primarily consistent of $546 million in a reduction of acute care hospitalizations and 200 million reduction in skilled nursing facility spending, offset by an $87 million increase in outpatient emergency room and observation stays. So some of you have heard what my take is on this. And my take is that we have a situation where, yes, the Medicare fund may have saved $949 million in those 9 states in those 5 years, due to the things that you see on the screen. But the reality is home health agencies in those 9 states allowed an increase of emergency department visits of 6.4%. When they got to the emergency room, the hospital refused to let them back in the door and held them in observation, et cetera. And then we're getting credit for it. And you know as well as I do that the not letting them back in the door at the hospital was to protect, I'm going to get it out in a minute, the acute care hospitalization rate of the hospital itself. And so they're giving us credit for something that, to be honest, I don't really think is due to us solely. But the reality is, here we are. And so we're getting credit for it. And the acute care hospitalization emergency department use is 35% of our total performance score. So we have to pay attention, and we have to make sure that we are protecting our total performance score in value-based purchasing by seeing a reduction in emergency department and hospitalizations. Sometimes I get that that's beyond our control. But for the most part, we hope that you can maintain low levels of patients going back to the hospital. Okay, this next screen is also from that 5th annual report. These screen shows you the total performance scores for the value-based purchasing states in blue, for all other states in orange. So basically what they've done here is they've taken all of the same data for all agencies in the nation for the 5 years of the value-based purchasing model, and made the calculations even if that agency state was not in the model. So the blue, again, is the 9 states that were in the model. Orange are the states that were not. So the reason I wanted to point this out to you today and show it to you is to make sure that you're clear that while many agencies have said, oh, we didn't get to participate in the demonstration, so we're that far behind. You're not that far behind. You may not know the detail ins and outs of how value-based purchasing works. Hopefully a lot of that will be resolved today if you don't know it. But scoring wise, you're not that far behind. I mean, look at the scores on the screen. They are very, very similar to the scores that we were seeing in the value-based purchasing states. The value-based purchasing states are ahead just a little bit, but we would anticipate that they would be because of the stringent focus that many of them had on the value-based purchasing items. But hopefully it will help you realize that you're really not that far behind. Okay, so this next screen, this is for the 9 states that participated in the model. This is for the 4th year of payment, or the 4th year of the demonstration, I guess I should say. Each of the states are here with, in red, the 25th percentile of scores, the 50th percentile of scores is in green, and the 75th percentile of scores is in purple. What I want you to note is a couple things. First of all, Florida has the lowest scores in each of the percentiles, 25th, 50th, and 75th. They have the lowest score across the board in all of the percentiles. So what does that mean? That means that when we put, even if we just put all agencies in these 9 states in the same bucket, The score that you see for Florida, that's their 25th percentile score, which is 30.2, would not be in the 25th percentile if we put all of these agencies into the same bucket. So what I'm saying is, when we get to a nationwide rollout where all agencies in the large cohort are put into that same 7,500 patient bucket, the scores are not going to hold true. And so getting to the 75th percentile of the state for Florida, you only needed a score of 44. But as you see in Washington state, which is to the far right, in Washington state, to get to the 75th percentile, you needed a total performance score of 63. And so my point again, you put all of these agencies into the same bucket, a 44 is not going to be anywhere near the 75th percentile. And so I hope that if you are in one of these 9 states and did participate in the value-based purchasing model, that you see the situation and take it into yourself to understand that when you get put into a bucket with 7,500 agencies, your scores are going to look very different from what they may have looked like during the demonstration, especially in putting them into the 25th, 50th, and 75th percentiles. Also know that regardless of whether we're talking about the demonstration or we're talking about the nationwide rollout, the 51st and forward percentiles are going to be the ones that see a positive impact on their future reimbursement. So if you are below the 51st percentile in the calculation of your total performance score, you are likely going to be in a deficit situation with a reduction in your future payments. So this next screen, they have messed with the colors a little bit. And when we get to the next screen, this is the calculation of those same scores you just saw on the previous page. This is the reimbursement impact that was calculated from those scores. And you see Florida is all the way to the far right, which shows that in their 99th percentile, I said they changed the colors on us a little bit. The 99th percentile is in purple, 75th percentile is in green, 50th percentile is in red, and the 25th percentile is in blue. And so in the 99th percentile, Florida has the highest reimbursement. If you look at their 75th percentile, this is the one that'll make the most sense to you, I believe. When you look at the 75th percentile, Washington State's reimbursement calculation and Florida's are almost identical. But if you go back a screen to the 75th percentile, in Washington State, the 75th percentile was a 63. In Florida, the 75th percentile was only a 44. So how do you have a score of 44 in Florida and a score of 63 in Washington State, and they both turn in to almost identical percentages of increase in payment? That happens because in the demonstration, agencies in Florida were only compared to other agencies in Florida. So a score of 44 is going to get you more added to your reimbursement, where in Washington State, you had to get to a 63. And so again, we put all those into a bucket. Florida's agencies that were scoring 44s and getting into the 75th percentile are going to be way down, probably closer to the 50th percentile. We don't know yet what those numbers are going to look like. But the reality is they're not going to be where they were during the demonstration. So again, if you were in the demonstration, I hope you see the reality that once you're put into a big bucket with everyone, your numbers are going to look totally different. Okay. Last year's final rule is when they finalized that value-based purchasing will begin January 1st of 2023. They had originally proposed in 2022 that 2021, that it began in 2022, which means we would already be 9 months in or 8.5 months in to this rollout if that had gone through. But we convinced them that they absolutely could not do that. And the other 41 states needed some education before they were thrown into this thing. So here we are entering 2023 and a nationwide rollout. Pretty much everything that they put in place in the final 2022 rule stands for the implementation of the model in January of 2023, with the exception of in the proposed rule for 2023, they have had the discussion of possibly changing the baseline year to now be 2022, where in the original final rule, it was going to be 2019. So we will talk about that a little more when we get there. But other than the baseline year possibly being changed, everything else within the original final rule for VBP remains the same. So with the value-based purchasing implementation, there will be two cohorts, a small cohort and a large cohort. In order for you to be in the small cohort, you will have to have seen less than 60 unique survey eligible beneficiaries in any calendar year. So if you have less than 60 patients that were eligible for the HHCAP survey, you would be considered in the small cohort and not required to participate in HHCAPs. You do have to file a formal request for exemption in order for you not to be required to participate in HHCAPs. So you want to make sure that is clear. With the large volume cohort, that is any agency that has seen at least 60 unique patients in a year and is required to participate in the HHCAPs model. As I've already referred to, in that large volume cohort, there's approximately 7,500 agencies. In the small cohort, there is about 550. So many of you might be confused at those numbers because there is a lot of things that you might read or see that says or alludes to there being 12,000 home health agencies in the nation, et cetera. Understand these are Medicare certified only home health agencies, meaning they're not Medicaid agencies or Medicaid only or private duty or whatever. They are Medicare certified agencies. So 750 approximately in the large cohort, 550 plus in the small cohort. As we get into 2023, the payment adjustment that you will have at risk is 5%. Understanding that that 5% is the maximum up or down from zero. In a 5% year, everyone, not everyone, but the majority, the large majority, like 99% majority, are going to fall between 2.75 up or down from zero. It is not, there's going to be very few, if any, that push the 3.5, 4%, especially in a positive light. The majority are going to be between 2.75 to 3% each way. It is not a situation where you have to worry about that 5% in the first year, meaning they're not holding money or they're not deducting money and then they're going to pay you back, that kind of stuff. The 5% impact is calculated after the first year of performance is completely finished. So once we completely finish 2023, they will finish the calculations in 2024, and then those will impact your payments in 2025. And so a harsh realization for some of you who may be new to home health or who may be growing in home health, meaning adding patients. An agency said to me recently, so are you telling me that if in 2023 we have 100 patients and we get a negative 2% as a result of value-based purchasing, and I get to 2025 and I now have 300 patients, that all 300 patients are going to have a 2% reduction in payment? And that is exactly what I'm telling you. And so the opposite could be true as well. You could have 400 patients now get a 2% reduction as a result of your first performance year, and in 2025 only have 100 patients that it applies to. Obviously, we don't want to go that direction, but the reality is it's going to be, regardless, The calculations will be made based on your 2023 performance, and then it will be deducted from every claim payment that's made in 2025 for traditional Medicare, regardless of the volume compared to 2023. The baseline year, as I mentioned a few minutes ago, is the only thing that is up for grabs as far as the proposed rule that we are currently waiting to be finalized. In the original proposal, they did propose 2019, and in May of this year, they issued the benchmarks and achievement thresholds based on the 2019 year. If they do decide to change in the final rule the baseline year to 2022, they will not have benchmarks and achievement thresholds for you to use in any calculations or software systems, etc., until July of 2023. And so any of the software vendors, EMR systems, etc., that have started developing softwares that will assist you in knowing real time where you stand in the value-based purchasing calculations, they have all started using the 2019 data that CMS issued in May, and they've pretty much come to the consensus that they will continue to use the 2019 data to give you as current information as they can until they get the benchmarks and achievement thresholds from 2022. When asking a crowded room in the form of an open session in speaking engagements, I've asked several groups of people if they care. Do you want it to be 2019? Do you want it to be 2022? And nobody really knows the answer. Or if they know the answer, they don't really have an opinion. And so some agencies think that their scores look a lot worse in 2022 because of the public health emergency they've been dealing with and lack of staff, etc. If your scores are really bad in 2022, as far as outcome measures are concerned, you may want it to be 2022, so that if you're able to focus on value-based purchasing in 2023, then you're going to have huge improvement scores because you're going to do so much better than you did in 2022. So that's my take. That's what a lot of people have been saying as well. We just don't really know where that's going to fall. During the 2022, or actually 2023 proposed rule that we're still waiting to be finalized, they did clarify definitions for a couple of terms used in value-based purchasing. One of or two of those is the baseline year language, agency baseline year versus model baseline year. All you really need to know about this is that your agency baseline year and the model baseline year will always be the same, assuming that you were Medicare certified prior to January 1st of the model baseline year. So if they change the baseline year to 2022, as long as you were Medicare certified prior to January 1st of 2022, your baseline year, agency baseline year, will also be 2022. So when we get to the calculations in a few minutes, I'll explain a little more what it means as far as agency versus model baseline year, and hopefully it will make more sense. So these are the items that you see on the screen that are going to be used specifically to calculate your total performance score under value-based purchasing. The OASIS items that you see on the left, the top three, are individually calculated outcomes. The next one, the total normalized composite change in mobility, is 3 items combined. And then you have the self-care measure that combines the scores of 6 items. In addition to that, on the right, you see HHCAPS data, where the HHCAPS survey data, there are several questions that make up 5 different measures that will be used there, and we'll talk a little bit more about those toward the end of the presentation. Then we have claims data that will come from hospital claims that will reflect and be used in the calculation of the acute care hospitalization measure and the emergency department measure. Understanding that these two measures, the acute care hospitalization and emergency department use without hospitalization measures, are both going to be extinct as far as the home health quality reporting program is concerned as of January 1st. However, they are still going to be calculated exactly as they have been calculated in the past, to be used in value-based purchasing. But they will not be used in this form in the home health quality reporting program. They will be, there is one single outcome measure that will be used in the home health quality reporting program that will replace these two. We do feel like that in future years, they will remove these two from value-based purchasing and add that one that's used in the home health quality reporting program, but that has not been the case for 2023. So these are the minimum numbers that you must have of the data that we just looked at in order for you to have value-based purchasing measure calculations. There has to be at least 20 home health quality episodes. Quality episode defined as start of care to transfer, start of care to discharge, resumption of care to transfer, resumption of care to discharge. Understanding that to actually make an outcome calculation, you have to have the question at both the start and the end. So for the most part, you're going to have discharges that have the actual questions on the discharges that can be compared to the start of care or to the resumption of care to make the calculation. So you got to have 20 that outcome calculations can be calculated for. You also have to have 20 home health stays in order for them to calculate your acute care hospitalization rate. And you have to have at least 40 completed HHCAP surveys returned by your patients in order for you to get HHCAP scores. In addition to that, you have to have at least 5 of the 12 measures to calculate a total performance score. So if you didn't have enough to do claims and you didn't have 40 HHCAP surveys returned, you would only have OASIS left, and you would have to have at least 20 episodes where all 5 measures in the OASIS would be able to be calculated for an outcome measure, or you won't get a TPS score at all. When we talk about having to manage this situation and knowing for sure where we stand as far as the results and what we need to work on, etc., reports are all we have, right? And barring you having an individual software system that's going to keep you up to date as to where you believe you are at this point, you're going to be reliant on the reports that you get from CMS. From CMS, you're going to get an interim performance feedback report, and I will show you the schedule for that in just a moment. It does not begin until July of 2023. And then you will get an annual total performance score report, and then an annual payment adjustment report. Both of those will give you the calculations of how your payments will be affected in future years. And so this is the schedule that you see on the screen. July of 2023, as I've already stated, is going to be the first reports that you will see. And as you see, those are 12 months ending 3/31. So this is a 12 rolling month report. All of them are. You have to understand that if you were only going to use January through March data, that there would be little to no calculations of outcomes that are going to exist, because you would have to have a start and an end. And even if you had enough 20 in the calculation requirement, even if you had 20, is that going to be a true representation of what your outcome should look like? And the answer is no. So they are using 12 rolling months. So when you get those first reports next July, technically for next year's purposes, you're only going to have 3 months of live data, 9 months that will not be used. You will not have any claims-based data or HHCAPS data outcome calculations until we get to October of 2023, and even then you're only going to have 3 months. You will not have a full 12 months of OASIS until April of 2024, and 12 months of claims and HH caps until July of 2024. And then in August of 2024, you will get preview reports for the total year. This next screen tells you the fact that you are able to ask for a recalculation of your IPR reports if you feel like the calculations are incorrect. What you do have to make sure you realize is that if you are going to request a recalculation of your reports, you cannot request a recalculation without giving them detailed reasons as to why you feel like your numbers are wrong. You can't just say, I want a recalculation. You have to be able to tell them why you believe your numbers are wrong. You will also get the preview annual report, and you will be able to ask for recalculation of that as well. And then you will get the preliminary annual report that you do have to request a reconsideration within 15 days if you intend to do so. Do understand that with the preliminary annual report, you will not be able to request a reconsideration if you did not request a recalculation of the preview annual report. So you need to make sure someone is monitoring your IKEY system, which is where the reports will be flowing at the time periods represented, and make sure that you are clear that we have to appeal or ask for a recalculation of the preview report, and follow that up with a reconsideration of the preliminary report if you don't get results before then. This is a timeline just laying out the situation with the reporting and giving you some idea of when you're going to get those interim reports. Before we get into the details of the calculations of the achievement and improvement scores, these are the thresholds that will be issued and utilized in the calculation of your payment. The achievement threshold represents the 50th percentile or the median score of all Medicare home health agencies for the baseline year. The benchmark is the mean of the top 90th percentile of all home health agency performance scores on the specified quality measure during the baseline year. The benchmark and the achievement thresholds will always be based on the model baseline year. So right now that's 2019. They are possibly going to change it to 2022, depending on what they decide when issuing the final rule. Again, if your agency was Medicare certified prior to January 1st of 2019, if the baseline year stays at 2019, then your improvement threshold will also be from 2019. However, if they change the baseline year to 2022, you would have to have been Medicare certified prior to January 1st of 2022 to, first of all, even participate in 2023 and to have your baseline year for improvement threshold in 2023. So the improvement threshold is your individual performance score from the baseline year. The baseline year will be the same as the model as long as you were Medicare certified prior to whatever year the model is using as the baseline year. These are the 2019 numbers that CMS issued in May. And so if the model baseline year stays at 2019, these are the thresholds, both benchmarks and achievement thresholds, that will be utilized in the scoring next year. If they change it, they will have to issue new benchmarks and achievement thresholds for 2022. And again, we will not get those until July of next year. The thing that you see missing from this screen compared to the previous screen is the improvement thresholds. The improvement thresholds are going to be your individual agency's scores from the baseline year. And again, if you were Medicare certified prior to 19, it's going to be your 2019 scores. Those improvement thresholds will be issued to each individual agency and should appear within your IKEYS reports. Okay, so in the calculation methodology that is being used, this is the exact same methodology that was used during the value-based purchasing demonstration. And this is where all of those thresholds come into play. Anytime you see the term performance, the performance score means the score that the home health agency had in that performance year. So next year, when you see performance score, that's going to be whatever outcome calculated score you get for 2023. Then in the calculation for achievement, they're going to take that score, subtract from that the achievement threshold, which I showed you a few minutes ago, and then divide that by the benchmark, the high lofty 90th percentile of scores, minus the achievement threshold, the median of all home health agencies. And then the result of that, you're going to multiply by 10. The next calculation is for improvement. The improvement calculation takes your current year score in 2023, subtracts from that your improvement threshold, which was from the baseline year, divide that by the high lofty benchmark minus the improvement threshold, and then you're going to multiply by 9. Once you have an achievement score and an improvement score, the two will be compared and you get the higher of the two scores. So on some of these outcome measures, you may get higher achievement scores. On other, you might get higher improvement scores. You may get a 0. How does that happen? So in order for you to have an improvement calculation, for this calculation you see on the screen to even happen, you have to score in the performance year, which of course next year will be 2023. Your score in 2023 has to be at least as high as your improvement threshold, which was your score in the baseline year. If you don't score as well as you did in the baseline year, your score for improvement is automatically 0. When we go back a screen for achievement, your score in the performance year must be at least as high as the achievement threshold, which is the median score of all agencies in the baseline year, or you don't get an achievement score. That being the case, your achievement score will be 0. So if we go back to this screen, you see that the benchmark for oral meds is 93.361 and the achievement threshold is 73.580. If you do not score at least a 73.580, you will not get an achievement score. Your score will be 0. If the opposite of that, you score at least a 93.361 or higher, you automatically get 10 points. So if you hit the benchmark, the high lofty, high score, if you hit the benchmark in the performance year, you automatically get 10 points. Calculation stops there. If you don't hit the benchmark, but you at least get a 73.580 for achievement, then it's going to go through the calculation for your achievement score. And then in your IKEYS reports, you'll get your individual improvement threshold. And if your score for that year is at least your improvement threshold, you'll get a calculation for improvement. If it's not at least as high as your improvement threshold, you will get a 0 for improvement. So there are some of these measures that some agencies may get a big fat 0 across the board. So you want to make sure to follow those and know where you are in those calculations. So this is the scale that tells us where each of the measures that are going to be used in the calculation of your total performance score stand as far as their percentage of impact on the overall process. So the OASIS items that are utilized, the measures that are utilized to calculate your total performance score, represent 35% of your grand total score, with your self-care measure and your mobility measure each being 8.75%, oral meds, dyspnea, and discharge to community all being 5.83% each. You then have claims data where these two items alone are going to represent 26.25% acute care hospitalization, and emergency department 8.75% of your grand total score. And so please hear me clearly that while acute care hospitalizations you don't have massive control over in all cases, you need to try to figure out how you can have better control if you don't have great numbers right now, because it is 26% of your total score. So you really want to make sure that you're focused on that. The HHCAHPS measures you see at the bottom of the screen in total were 30% of your total performance score, with each of the individual 5 measures being 6% of your grand total score. Now, what are these other items or columns on the screen? The other columns on the screen represent situations where you don't have enough data. So let's say that you are an agency that's in the small cohort. You do not see at least 60 eligible patients a year. So you don't have to do HHCAHPS and you're in the small cohort. So you would be in this column that says no HHCAHPS. Your OASIS measures would represent 50% of your total performance score, and your claims data would represent 50% of your total performance score. So in the small cohort, you already have increased focus on your acute care hospitalization rate because it's 37% of your score now. Also understand that this column will also be what is used for your calculations if you're in the large cohort, but your patients do not return at least 40 HHCAHPS surveys in a given year. So you get to 2023 and you only get 30 surveys returned the entire year, you're going to be in the second column with no HHCAHPS scores, and you see the 50-50 split between the other two divisions. The third column is no claims data, which means you don't have at least 20 stays that apply. And then the last one would be if you didn't have enough claims or HHCAHPS, then OASIS would represent 100% of your score. So I think it would be valid to say if you're in the large cohort, the majority of you will be able to focus on the first column and know what percentage of impact each of these items have, be able to look at some of your current outcomes data, especially if you're in a value-based purchasing state before, and know where you need to focus. But we're going to talk about how to pull that out in just a few minutes. So this next screen is the linear exchange function. This is exactly the calculation that is used to determine through calculation exactly what the impact on your future year payments is going to look like. So we want to be obviously positive, but this is going to tell you for sure when using data from all agencies that are in your cohort to make that calculation. Obviously, the screen only has 8 home health agencies listed on it. If you're in the large cohort, there will be 7,500 approximate agencies on the spreadsheet when these calculations are made. So I'm going to take you through the calculation, and please make sure that you're typing in questions if you were to have any questions about this calculation. So in the first column, C1, this is the total performance score column. So if you go back and look at each of those questions, those measures we just looked at, there will be a process of calculating the outcome for those questions, and the outcome score is then put through the achievement and improvement calculation, and then whatever score comes out from that is what will be added all together for each of the 12 measures combined to get you to this total performance score that you see in C1. Understanding that the maximum points you can get is 100. So technically this 38 is 38%, really. But anyway, that is what column C1 is. C2 is simply the total Medicare payments that you received in the prior year to the year that's being calculated. So if they're doing the calculations for 2023, this dollar figure will be the dollars that you were paid for 2022. Then we take in C3, step 2, we take column C2, which is your total Medicare payments from the prior year, and we multiply that by 5%. And then column C3 is the column that represents the total amount that you had at risk based on 5%. And then in the next column, we're going to adjust what you have at risk based on your total performance score. So you have a total performance score of 38. 38 divided by 100 is basically 38%. 38% times 5,000 gives you $1,900. So based on your total performance score, you technically only have $1,900 at risk. This calculation then is used in step 4, C5, where they take the grand total of C3, which is 172,611 in this example, divide that by C4, which is 89,379 to give you 1.931. And then that is the linear exchange function number, and it is put into the column and applied to all. So in step 5, C6, they take C4, the 1900 total adjusted total performance score, adjusted reduction amount, and multiply that by the linear exchange function. And in this example, 3669 is the first number. So if you look at the very bottom of these totals, column C3, the total 172,611. Go to C6, the total 172,611. So how is that possible? This value-based purchasing model does not have a profitability factor for CMS involved. Meaning, if they're going to take money away from one agency because of their poor performance, they're going to give it to the agencies that have good performances. So we go from having 172,611 at risk at 5% to converting that to see what that looks like based on the agency's performance scores to still come up with the 172,611. That number is then converted to a percentage based on your original Medicare payments. So in the first example, 3669 divided by 100,000 gives you 3.669%. That percentage is then from that, you take this percentage and subtract 5%, and then that gives you column 8. And then column 8, or C8, is the column that is the amount that's either going to be taken away from or added to your future payments. And so we look at the agency that scored a 22 on the total performance score. And again, 100 is the maximum. So 22 is a really low score. We have a 22. And if you follow that all the way over to the right, in the end, that agency is going to have a 2.876 reduction in payment in 2025. But then you look at the agency just below that, that scored an 85, which is not going to happen, by the way, but 85, follow that all the way over to the right, and you have a 3.2808% positive response, which means 3.208% added to your payments in future years. So want to make sure that we're simply clear about the reality. The higher your score, the more positive impact you're going to have on your payments in future years. Now, for example purposes only, this agency that scored a 50, you follow it all the way over to the right and you see that it's a negative 0.172%. As I said earlier today, you're going to basically have to be in the 51st percentile in order to get a positive result. I want to make sure you are clear that while this is basically a zero application for a score of 50, I am not telling you that you have to go out and get a total performance score of 50 and then you're going to be fine. That's not what I'm saying. I'm saying your scores are going to have to be in the 51st percentile of the nation. We don't know what that score looks like yet. That 51st percentile score, you may have to have a 60. We just don't know what everyone else's scores are going to look like yet. But if you want to be in the positive, as far as your payment impact is concerned, you need to be at least the 51st percentile of scores. Again, not knowing yet what that's going to look like. I don't see any questions in the queue, but if you do have questions about any of the calculations that we've looked at so far, please don't hesitate to put those in. So the next 2 or 3 screens, we're going to look at what you should be looking at, what you should be looking at internally to figure out where you stand in value-based purchasing and what you should be doing to get ready for that. So comparison of actual performance with your potential or needed performance is what we're looking at here. How you discern that, how you decipher what you need to work on next. The foundation for measuring investment of time, money, and other resources required to achieve a particular outcome. This is all part of a gap analysis. Value-based purchasing gap analysis should consider operations, clinical, and financial. Get people out of the silos. What does that mean? That means we don't have a company, or should not have a company, where financial doesn't talk to clinical, clinical doesn't talk to operations, operation doesn't talk to financials, etc. Everybody's doing their own thing and nobody cares about the other. We can't operate like that, and we're not going to be successful, and we're not going to be able to truly meet the requirements and be positive in value-based purchasing if we're all operating in individual silos. It just cannot happen. So you've got to look outside of traditional Medicare fee-for-service, meaning that's not the only thing you can look at, because in the transmission of your OASIS data, you are going to have reported Medicare, Medicare Advantage, and skilled Medicaid patients. If the proposed rule that has been issued for 2023 goes through and is finalized the way it was proposed, there are actually going to be requirements for every patient you have, regardless of payer, to have OASIS completed and transmitted to the database. That being the case, you're going to have some strong negative impact with some of your payers that you're now going to have to transmit OASIS data for. And that's going to be a struggle. So we need to make sure that you are not just looking at your traditional Medicare patients or your traditional Medicare outcomes calculated on those patients, but you're looking at outcome calculations across the board. Whether you are aware or not, the star ratings and the publicly reported data on the Care Compare site are already utilizing the Medicare Advantage and skilled Medicaid patient documents that are already required to be sent in. When you're trying to decide what you want to do here with a gap analysis, you need to really identify exactly where you are today and where you need to be. And then obviously, in identifying where we are now, you're going to be looking at several different reports, several different pieces of data. If you were in a value-based purchasing state prior, then obviously you're going to have quite a bit of information to start with, because you're going to know at least where you left off at the end of 2020, because they did issue the reports, even though they're not going to impose the financial impact on agencies. If you do not have those reports, or you did not participate in the value-based purchasing demonstration, you can look at your care compare results, your outcome reports in IKEYS, etc. Now, understand completely, please, that the CASPER reports and outcomes that are calculated for the star rating are not going to be identical to the calculation, et cetera, for value-based purchasing, but they're going to be extremely close. And so at least you have somewhere to start. As far as defining problem areas, you're going to need to look at those outcome measures from the stance of determining obviously what your lower scores are, and definitely where your lower scores are compared to other agencies, if you have that kind of data. If you do not have a software system, that a third-party software that does these calculations, you definitely might want to consider that, where they have nationwide volume to compare your data to. It may be that you've identified problem areas in audits. It could be that you have discovered the OASIS items that also are involved in value-based purchasing that are included in the PDGM calculation of your HIPS code. You're finding problems with. Those are directly related and might be an area of focus. When we talk about the responsible staff, we need to talk about this in two different ways. Who's going to be responsible for doing this analysis to determine where we have gaps in the process? But you also need to put there that you need to identify responsible staff for the problems, meaning if we are having poor outcomes in therapy patients, is it therapy documentation that is leading to that? Is it lack of adequate therapy treatment that's causing us to have negative outcomes? What is the deal here? How do we identify that? The data required and the source of data is going to be determined by what access to data you have, whether it's in your EMR system or you have a separate software system, you're using the IKEYS reports, etc. Where are you going to get this data? Somebody needs to really sit down, look at what you have. Many times there's report data, information, etc. within your own EMR system that you don't even realize is there. But somebody's got to do the digging to find out for sure what data you're going to need and where you're going to get that data. Identify any bridges or how you're going to bridge the gaps that you find. How do we get to where we need to be? Where do we start? Do we need to define new processes? Do we need to replace people? And that's a really hard one, especially in today's day and age, when I know many of you are struggling just to have enough staff to keep your doors open and to treat your patients. So I get the people situation, I really do. But we have to be able to move forward, not only with value-based purchasing, but know that we're getting paid what we should be getting paid, know that we can pass medical review with any of the documentation that we might have in our charts, etc. And if the people that you have are not making that happen, you may have no other choice but to look for other people. Processes obviously need to be looked at frequently. And in many cases, the process is not happening the way they need to. Sometimes the processes themselves are bad. But in the absence of bad processes, it's the people that are not implementing the process the way it needs to be. And we need to figure out what that is. That might include your QA process. It could be that the process by which you're having OASIS reviewed, or the process that you might have in place for HH caps may not be what it needs to be. You've got to look and pull every piece of the onion off to determine what exactly is going to need to be reviewed, what exactly has holes in it, what we need to do to fix it. It may be that we need new technology. As I've already mentioned, you may need access to a software system that's going to help you keep up with this with real time. It may be that your current EMR system already does that. It may mean that you need something added to what you currently have. And believe it or not, we still have agencies out there on paper. And it may mean that you need to move into an EMR. It may mean you need to move to a new EMR. So the reality is we got to figure out if we have what we need technology wise. As far as time is concerned, how much time are we going to give ourselves to fix this problem? And you need to define how long it's going to take you to build that bridge. And you need to have time periods that you're following up on that to make sure your timeline remains what it needs to be to effectively get to the end result of a permanently built bridge and getting rid completely of the gaps that exist that are keeping you from being successful, not only with value-based purchasing, but with star ratings, with payment, etc. Define necessary tasks, assign those to responsible parties, and reconsider gaps continuously, meaning you need to constantly be looking at what's happening, the outcomes that are happening, etc. And have we gotten to a point where we feel like the gap is being closed on one item and there's another gap that's being identified that we need to continue to work on? Lots of different places that you can get information, really dependent on what you're looking for. There are probably many more cost-effective things out there in the form of free data, et cetera, from your Casper reports, your IT systems, the CMMI website, which is part of the CMS website, but specifically dedicated to value-based purchasing and some other programs, depending on what you need. You need someone that is stellar at determining what your agency specifically needs and how you're going to get it. And research sometimes is that. So this is all of the stuff that I mentioned just a second ago. Casper reports, the information you find in iKeys, the CMMI expanded website, the HHCAPS vendor. You might want to consider getting a new HHCAPS vendor if the one that you have now is not making it happen the way you need it to happen. And again, your EMR vendor may need to be replaced. So the last few minutes that we have together today, I'm going to touch some of the highlights of the OASIS items and the HHCAPS items that are used in value-based purchasing. I know that many of you feel like you have educated on OASIS until you just can't educate anymore. I challenge you to go through each of these screens and look at some of the scenarios that we have provided in these screens, because some of these scenarios that have been put together for the OASIS itself, I've been in rooms of people. In fact, I was just in one yesterday where half of the room said the answer was one thing and half of the room said the answer was something else. And what that says to me is if your higher level people are in a room that are the ones responsible for your field staff getting educated, and those people are giving me half one answer and half another, then what is your field staff doing? And so you really need to take a detailed look. Many times it's that your clinicians are completing these OASIS items routinely the same way they've been completing them for 20 years. And the sad part is, in some cases, they've been doing it wrong for 20 years. In other cases, it could be new staff that told you that they did OASIS for 5 years somewhere else. You didn't test them, so you don't have any idea what they know or what they don't know. And it winds up that they don't even have the right information to be able to complete it. Chapter 3 of the OASIS Guidance Manual needs to be utilized as your OASIS Bible. And all the guidance that is within that chapter 3 of the Guidance Manual needs to be at the fingertips of your field staff that are performing OASIS assessments, and you need to make sure they have what they need. So some of the general guidance for the 1800 items we've listed here. One of the biggest factors that we see being impactful in getting the right decision, especially to the 1800 section, is making sure that your staff are taking into account safety. And even if the patient is currently performing the task, that does not mean that they're performing the task safely or that they should be performing the task at all. So you've got to make sure that they're doing that. Another thing I want to point out is that the 1800 items do not directly correlate to the GG items. There are many cases when they may be titled similar, but the content of what's included or excluded is different. Also, in the majority of cases, the GG items are looking at the percentage of help that a patient may need or assistance that a patient may need, where the 1800 section is looking at the agency's ability or the patient's ability to perform. So you want to make sure you get that straight. As far as grooming is concerned, we're not going to go through the details of this. We have given you a patient scenario and the rationale behind the response. You'll want to look through those. As far as dressing the upper and lower bodies, you do need to make sure you're taking into account all things that they have to put on or take off in dressing both upper and lower. You also need to make sure that included in the guidance for these two questions specifically, you are to look at the percentage that they can do versus the percentage of items they cannot perform. In other words, let's say we're talking about lower body and the patient has to put on undergarments, pants, belt, socks, shoes. That's 5 items. And if that patient can put on everything except his belt, then that patient is going to be considered independent because they can do 5 out of 6 of those things completely independent. So you need to look at the majority of things in both of these items. For the upper body, we have given you a scenario with the appropriate response. We have done the same thing with the lower body and the answer for that. The bathing question is going to be a question that just drives me completely insane. Extremely frustrating question in the sense that the bathing question asks about the patient's ability to wash their entire body safely. And then you get frequently asked questions from CMS that say if the patient's bathtub doesn't work, then they can't use it. So frustrating in the sense that we are talking about in the actual question itself, can they wash their entire body? And then we get into the response options and we're already a 4 just because the patient's bathtub doesn't currently work. So there's that. Toileting hygiene is the next item. We have given you some pretty significant instruction on the toileting hygiene question, or guidance, I should say. The feeding and eating question, you do need to make sure you reiterate to your field staff completing these documents that eating, chewing, and swallowing are what is to be considered for this question, not preparing the food to be eaten. Okay, that was the mobility items. The self-care items. The next 3 items are the mobility measure combined for the mobility measure. In this scenario, or this question, is the toileting transfer question. As many of you know, the toileting transfer question has been around for a minute, but before it was called toileting. And that toileting question was simply, can the patient get to the toilet and back again? It did not care about what the patient did when they got there, which doesn't make any sense to me at all. But that is the reality of the situation. So now we not only have to get to the toilet, we have to transfer on and off the toilet and get back to where we were before. So very important question. We have given you some significant guidance to that toilet transferring question, and we have given you a scenario. However, yes, we did. We gave you the answer. There it is. There's the response to that question. On most of these scenarios, we have also given you what the corresponding GG item would have been. I shouldn't say corresponding, because technically these questions are not the same. For example, toilet transfer in the GG items does not include getting to and from the toilet. It only includes transferring on and off the toilet. It does not include getting to and from. So we have given you some of that guidance as well, and responses to any scenarios that we included, inclusive of a related GG item or possibly related GG item. The transferring question, a very significant question. While the GG items and the 1800 items don't directly correlate, it is imperative that you're not saying in one item that they can walk a mile, and in another item say they can't get up off the couch. There will be some conflicting answers between 1800 and GG possibly because of the way they're asked. So you have to understand the full content of the question, the intent of the question, and the response options available to the clinician to make the determination as to whether there is actually a conflict or not. Additional guidance on the transferring question, and then we have a scenario with a corresponding answer on the next screen. This is one of the scenarios that half the room gets the correct answer and half the room is giving us another answer. So I would encourage you to go through this transferring question specifically and make sure that your clinicians are educated on the response and the rationale behind the response, and that they understand what that should look like. The ambulation question, one of the most important questions on the OASIS for multiple reasons. Not only is it involved in value-based purchasing and your PDGM calculations and your outcome calculations, but it is also used in medical review when looking at whether or not a patient is documented as homebound. If this question is marked 0 or 1, there are going to be extreme questions about whether or not that patient is actually homebound. So you'll want to make sure you take that into consideration. Some pretty detailed guidance from the guidance manual regarding ambulation is found here. And then here we have a specific scenario. This is the second scenario that I referenced earlier, when half the room got one answer and half the room got something else. Someone has just sent in a question, it looks like about ambulation. Do you have any suggestions on how to increase our ambulation scores? It seems like going from a two-handed device to a one-handed device is a huge jump and difficult to actually achieve. So there has, for a long time, been a problem with outcome calculations and the ambulation question. We have had the question expanded, meaning prior to just a few years ago, we only had like 3 options or maybe 4 to respond to this question. And then they expanded our options and put in the one-handed and two-handed device situation. When you say it's extremely difficult to get from a two-handed device to a one-handed device, I don't know that that's necessarily where you need to focus. We find that in many cases, in agencies that are struggling with the ambulation outcome itself, they are not taking safety into consideration, and therefore not even getting down to the point of a 3. Where if you look at the 3, it says able to walk only with the supervision or assistance of another person at all times. That is going to include cues, verbal cues, any touching assistance to help the patient balance, et cetera, et cetera. And this is the key. A lot of field staff are looking at a patient that may live alone, is ambulating with a walker to and from the toilet, et cetera, but is by no means safe in doing so. And if that's the case, then that is going to be a patient that can only walk with the supervision or assistance of another person at all times safely. And so that being the case, if you can get to a 3 where the patient is when you begin, then getting the improvement back to a 2 is going to definitely be much easier than trying to or having to get yourself all the way back to a 1. So Hopefully that helps. I really hope it does. Okay, so the ambulation scenario, another scenario again where we had a split response in the room, and you'll want to make sure that you get into that. So the last piece to this webinar is the HHCAPS survey questions. This first couple of screens are some information of what you can and cannot do as far as the HHCAPS survey is concerned, and what you can and cannot do as far as what you are telling patients, what your field staff are saying to patients, etc. The one thing you need to ask yourself is how many of our field staff, and that includes all field staff, not just nurses, therapists, aides, social workers, etc. How many of them have ever even seen the HHCAPS survey that goes to your patient? Most of the time you're going to hear people say, well, they've probably never seen it. Well, that is a total failure on behalf of the agency from the get-go. In order for you to be able to turn the curve, turn the corner of having positive outcomes with your HHCAPS surveys, your clinicians are going to have to be involved in getting positive responses from the patients. How are they going to get positive responses for the patients if they do not even know the questions that the patients are being asked on the survey? So there are 5 measures from the HHCAPS survey. The first measure is care of patients. That measure includes question 9, 16, 19, 24 from the survey. So if you look at the actual survey, it has like 40 questions on it. Question 9, 16, 19, and 24 are specifically used in the calculation of the care of patients outcome measure. You need to have an in-service with your staff, and you need to go through these 4 questions, and you need to talk about what within your organization makes it impactful so that your clinicians, your patients understand the question and are going to have a positive outcome. The next one is communications. Communication is question 2, 15, 17, 18, 22, and 23. So 6 questions from the questionnaire. You have a second in-service specific to the outcome measure of communication on HHCAPS, and you talk through these 6 questions and exactly what needs to happen with these questions and your processes internally to make sure you're going to get a positive response from your patients on those questions. The third in-service is going to be on specific care issues measure, which includes questions 3, 4, 5, 10, 12, 13, and 14. So basically, again, 6 questions from the entire questionnaire that are going to go into the calculation of specific care needs measure. You're going to go through those 6 questions in one single in-service and talk to your clinicians about how they can impact the results of these questions with your patients. And then lastly, there are 2 remaining questions, global items. Question 20, what number would you rate your agency from 0 to 10? And would you recommend this agency? This is the worst one. It should not even exist because you know as well as I do, we're getting patients that give us a 10 and then they turn around and say they wouldn't recommend us. It is frustrating, for lack of a better term. But it is what it is. And these 2 could be talked about in one in-service when you're doing something else, or you can talk about them throughout. The reality is you want the agency, you want the patient to believe that your agency is a 10. If your field staff do not consider yourselves, your agency, themselves to be a 10, how are they going to convince the patient they're a 10? You can't use the words, you can't tell the patient they got to be, that they need to give you a 10 or that you hope they give you a 10, etc. But just in the way that you take care of those patients and make those patients feel, if you treat them like a 10, they're going to believe you're a 10 and it's going to pay off. So this just talks about some of the things that you need to do. First and foremost, you need to get those 4 in-services scheduled. You need to get them on there, and you need to make sure you're including nurses, therapists, aides, social workers, and any staff in your office that are ever going to answer the phone and interact with patients. And you need to go through these questions from the CAHPS calculation of measures, and to make sure that your staff understand, to make sure that they understand the impact, make sure that they understand the process. You also need to implement a survey protocol of your own, where someone within your organization is calling family members and patients and asking questions. You cannot ask the exact questions that are on the questionnaire, but you can ask questions of the patient or caregiver to ensure that the care that you're providing to them meets their expectation, that they don't have any problems, that you're resolving any issues that they might have, etc. And I promise you, it is going to be impactful to your agency scores if you go down that process. If you would like to see us do any additional webinars this year that we don't currently have on the schedule, please send those thoughts to info@healthcareprovidersolutions.com. Thank you again for participating today. Thank you and have a great week.